Hi everyone, welcome to the Emergency Medicine channel. Myself Dr. Ashik Envy, doing post-graduation in Emergency Medicine. Okay, in this video, I would like to discuss about disorders associated with elevated blood pressure in pregnancy. That is our gestational hypertension, chronic hypertension, preeclampsia, eclampsia and HELLP syndrome. Okay, let's discuss one by one. So the definitions of each of the category is important. Okay, so let's start with the definition of gestational hypertension. Gestational hypertension. Okay, it is defined as BP, blood pressure more than 140 out of 90 millimeters of mercury for first time. Okay, it is detecting for first time during pregnancy. After it is diagnosing after 20 weeks of gestation. Okay, and BP should be returned to normal within 12 weeks of postpartum. Okay, and there won't be any associated proteinuria, no proteinuria. Okay, these three criteria should be met to call it as a gestational hypertension. Okay, now there is something called chronic hypertension. Okay, that is our second category, chronic hypertension. Here the BP should be more than 140 out of 90. Okay, but it should be there before the pregnancy or diagnosed before 20 weeks of gestational age. Okay, if it is diagnosed before the pregnancy or before 20 weeks of gestational age, it is chronic hypertension, or it is also like present like hypertension diagnosed after 20 weeks of gestational age and persist beyond 12-week postpartum. Okay, then also it is called chronic hypertension. Okay, it is not meeting the criteria for gestational hypertension. Okay, it is diagnosed, either it is diagnosed before 20 weeks or it persists after 12 weeks of postpartum. Then it is called chronic hypertension. Now moving on to the most important, preeclampsia. So the definition of preeclampsia, the gestational hypertension should be present. Gestational hypertension should present. Okay, that is BP is more than 140/90, and in association with the gestational hypertension there should be proteinuria should be present, then only it is called preeclampsia. Okay, proteinuria at a level more than 300 mg per 24 hours or more than or 1+ dipstick. Okay, then it is called preeclampsia or gestational hypertension without proteinuria, also preeclampsia presence. Okay, if there is no proteinuria, in the absence of proteinuria, if there is signs and symptoms of end organ failure, then also it is called preeclampsia. Okay, in the absence of proteinuria, there should be signs and symptoms of end organ failure, then also it is called preeclampsia. So preeclampsia can happen without proteinuria also. So now what are the signs and symptoms of end organ failure? So the signs and symptoms are, first one, a platelet less than 1 lakh. It is a sign of end organ failure. A creatinine more than 1.1 mg per deciliter. Okay. Or liver enzymes elevated more than 2 times. Okay, liver enzymes elevated more than 2 times. Or a new onset visual or cerebral, that is focal neurological deficit, cerebral symptoms, or pulmonary edema. Okay, these are the signs of end organ failure. Now let's discuss about preeclampsia in detail. So what are the investigations done in preeclampsia? Investigations in preeclampsia. Okay, you should look peripheral smear. Okay, peripheral smear to see schistocytes. Okay, schistocytes. The presence of schistocytes in peripheral smear suggests microvascular hemolysis. Okay, if it is present, it suggests microvascular hemolysis. Okay, then you have to check platelets. Okay, platelets, low platelet is a sign of end organ failure, and you have to look serum bilirubin and also AST and ALT. An elevated liver enzyme suggests severe preeclampsia. Okay, this will be elevated in severe preeclampsia. Then look for serum creatinine. Elevated serum creatinine also suggests severe preeclampsia. Okay, and you should look for serum uric acid. Okay, it is also would be elevated. Okay, and if possible, you can do a fundoscopic examination to examine the retina. Okay, and you can look hematocrit. Hematocrit may be elevated. Okay, and you can do a coagulation profile also. Okay, these are the investigation done in mother. Now for fetus, we can do a USG with biophysical profile, and you can do umbilical artery Doppler. Okay, and if there is you can interpret the umbilical artery Doppler like if look for the diastolic flow. Okay, in the umbilical artery Doppler, you have to look for the diastolic flow. Okay, if it is absent, you can terminate the pregnancy by 34 weeks. Okay, but if it is reversed, okay, the flow is reversed, if the diastolic flow is reversed, the treatment is nothing but immediate termination. You have to go for immediate termination irrespective of gestational age. Okay, irrespective of gestational age. Okay, so this is how you investigate a case of preeclampsia. Okay, now about prediction of preeclampsia. Okay, you can predict preeclampsia. Prediction of preeclampsia. Okay, if there is a diastolic notch on uterine artery Doppler, okay, done at 20 to 24 weeks of gestational age, okay, it will suggest there is chance for preeclampsia, okay. So now how to prevent preeclampsia, okay. So in order to prevent preeclampsia, you can use either low dose aspirin, okay, and you can take calcium tablet if hypocalcemia present, okay. Now moving on to the treatment part of preeclampsia, okay. The specific treatment of preeclampsia is termination of pregnancy, okay. You have to terminate the pregnancy. Now when should be terminated, okay. So the termination, the gestational age at which you have to go for termination is determined by whether it is a mild preeclampsia or severe preeclampsia, okay. It's mild preeclampsia or severe preeclampsia. So the criteria for mild preeclampsia is BP is elevated, but the BP should be less than 160/100 mmHg, okay, and there should not be any signs or symptoms of end organ failure, then only it is called mild preeclampsia. The severe preeclampsia is defined as BP more than 160/110 mmHg, and there may be signs or symptoms of end organ failure present, okay. So in case of a mild preeclampsia, you have to terminate the pregnancy at 37 weeks. That is, you can go for a gestation up to 37 weeks. But in a severe preeclampsia, you have to be terminated in an earlier period, okay. According to the guidelines, you have to terminate at 34 weeks of gestation, okay. That is the specific treatment. Now there are certain non-specific management of preeclampsia. The non-specific management include BP control. So the drug of choice of antihypertension in preeclampsia is labetalol, okay. Your other drugs include nifedipine. You can use nifedipine and alpha methyl dopa, okay. But certain drugs are contraindicated in pregnancy. They are nothing but ACE inhibitors and ARBs, okay. Angiotensin converting enzyme inhibitors and angiotensin receptor blockers are contraindicated due to teratogenicity, okay. And you have to start antihypertensives at BP more than 150/100 mmHg, okay. and all patients with impending eclampsia should be given MgSO4 prophylactically. Okay, prophylactic treatment with MgSO4 should be given to all patients with impending eclampsia. So what are the features of impending eclampsia? So the features of impending eclampsia include impending eclampsia. The first one is sudden onset headache, vomiting, scotoma, pulmonary edema, acute pulmonary edema, and epigastric pain. Epigastric pain. It may be due to subcapsular splinter hemorrhage in liver. So these are the features of impending eclampsia. So that's all about preeclampsia, and now we are moving on to eclampsia. The definition of eclampsia. Seizure that cannot be attributed to other causes in a woman with preeclampsia. There is a woman with preeclampsia developing seizure. The cause of seizure cannot be explained by other reasons. The only reason is preeclampsia. Then only it is called eclampsia. The treatment of choice in eclampsia is, it is not magnesium sulfate. Magnesium sulfate is drug of choice, but the treatment of choice is immediate termination of pregnancy. Immediate termination of pregnancy, irrespective of gestational age. But the drug of choice is EMG-ESO4, magnesium sulfate. Now how to give MgSO4? There are many different regimens to give MgSO4. Usually in the emergency department it is given as 4 to 6 grams IV in 100 ml aliquot. Over 20 to 30 minutes. It is followed by an infusion. Followed by an infusion of 2 grams per hour. 2 grams per hour, at least for 24 hours. 4 to 6 gram IV in 100 ml aliquot over 20 to 30 minutes, followed by infusion of 2 grams per hour for at least 24 hours. What is the mechanism of action of MgSO4? Mechanism of action of MgSO4. MgSO4 is also used as an antiarrhythmic. So there are 3 different kinds of mechanism of action. It is also used in bronchial asthma. In acute severe exacerbation of bronchial asthma, also magnesium can be used. So there are various mechanism of action of magnesium sulfate. Here the mechanism of actions include, first one is NMDA receptor blocker. NMDA blocker. Second one is, it will cause cerebral vasodilation. Third one is, it will block calcium channel. Calcium channel blockade. These are the mechanism of action of MgSO4 in eclampsia. Okay, now while you are giving MgSO4 as infusion in patient with eclampsia, you have to monitor certain things. Okay, because the therapeutic range of MgSO4 is 4 to 7 milliequivalent per liter. Okay, so you have to monitor for the MgSO4 toxicity. So how to monitor? You have to check patellar reflux, then monitor respiratory rate and also urine output. Okay, in case of MgSO4 toxicity, the first thing to be lost is patellar reflux. Okay, so usually a patellar reflux is lost at a concentration of 10 milliequivalent per liter. Okay, the therapeutic range is 4 to 7. At 10 milliequivalents per liter, patellar reflux lost. Okay, at a range of 12 milliequivalent per liter, okay, there will be respiratory depression. Okay, so that's all about eclampsia and management of eclampsia. Now we are moving on to the last topic, that is HELLP syndrome. Okay, so the criteria for diagnosis is, first one is it is a HELLP only is the mnemonic for the criteria. Okay, first H corresponds to hemolysis. So look the peripheral smear for schistocytes. Okay, examine the peripheral smear, and the bilirubin may be elevated more than 1.2 mg per deciliter. Okay, second is EL. Okay, that is elevated liver enzymes. Okay, so the SGOT will be more than 72, and the LDH will be more than 600 units. Okay, and the last LP is low platelet. Okay, so the platelet count will be less than 1 lakh. Okay, so these are the criteria for diagnosing HELLP syndrome, and the management or treatment of choice here also nothing but termination of pregnancy, immediate termination, irrespective of gestational age. Okay, so that's all about the hypertensive disorders in pregnancy. Okay, thank you for listening, and if you are interested in emergency medicine videos, kindly subscribe my channel. Okay, thank you.